Hello, everyone. Thank you for having me here. I'm going to be talking about irritable bowel syndrome, also known as IBS. This is a very common disorder and one in which our understanding of it has really evolved, especially over the course of my career. What does irritable bowel syndrome look like? It looks like the 20-year-old college student who gets severe abdominal cramping pain and diarrhea before an exam. It looks like the mother who is 40 years old who has ongoing constipation, gas pain, and bloating that gets worse after she eats. It may be a 65-year-old nurse with abdominal pain and bowel movements that consistently flip back and forth between constipation and diarrhea, with both being uncomfortable. The common thread for all these presentations is the presence of abdominal discomfort, either pain or gas and bloating, and altered bowel movements, constipation or diarrhea, or both. Irritable bowel syndrome is very common. It's estimated that it is present in approximately 15% of our population. Women are affected twice as often as men. Sorry. Symptom onset is usually sometime before or by age 40, and irritable bowel syndrome can really significantly affect quality of life. 60% of patients rate their symptoms as severe, and studies that look at quality of life in patients with irritable bowel syndrome compared to other disorders find patients with IBS rate their quality of life as worse than patients with many other structural GI diseases, patients with diabetes, and even patients with end-stage kidney disease. 25% of patients with irritable bowel syndrome seem to develop it after they have a severe gastrointestinal infection. There is also a strong association with history of trauma or abuse, with depression, anxiety, migraines, fibromyalgia, and sleep disturbances. How do we diagnose irritable bowel syndrome? There is no specific test for it, and I know many patients feel that this is just a label their doctor gave them because the doctor can't figure out what is really wrong with them. But that is actually not true. We make the diagnosis on the basis of very specific symptom criteria. We explore that for what we call alarm symptoms, which are symptoms that might make us concerned that there is another process going on. This might include symptoms of rectal bleeding, anemia, waking up in the middle of the night with symptoms, having a family history of other types of GI disease, or having an atypical presentation, such as developing the symptoms later in life. In addition, your doctor should also think about what other diseases could be going on. Many GI diseases can present with similar symptoms, so they should think about whether could this be celiac disease, could this be an infection, could it be inflammatory bowel disease. Thyroid disease can actually present with similar symptoms, as can pelvic floor muscle dysfunction. And then the doctor should decide what tests, if any, are appropriate to do to rule out any other possibilities that seem likely. So what causes irritable bowel syndrome? Irritable bowel syndrome is a functional disorder. This means there is no specific structural or tissue abnormality that we can pinpoint. It is not due to inflammation in the colon. It is not associated with an increased risk of cancer. It is not related to a deficiency in pancreatic enzymes. What we have come to understand it as is a disorder of the mind-gut axis. What do I mean by that? You don't realize this, but your gut is working for you 24 hours a day, day and night. Not only is it moving the food you eat along, it's digesting that food, it's secreting liquid in certain areas of the gut, absorbing liquids in other areas of the gut, and it even is an immune system organ. It is one of your body's primary defenses to infection from the outside world. All of this is regulated very exquisitely by a complex nerve plexus that we call the gut nervous system or enteric nervous system. It is very large and complex to the point that it has been nicknamed the second brain. This second brain communicates to your primary brain, through very direct nerve pathways that travel through your spinal cord and send signals that come from the gut up to different centers of the brain. And importantly, to centers that modulate pain and centers that modulate emotion. Similarly, there are other nerve pathways that travel directly from the brain down to the gut nervous system and modulate the gut nervous system and to control bowel function. Think of these nerve pathways as superhighways with signals traveling back and forth between the brain and the gut 24 hours a day. Now, the nervous system is an amazing thing, and it helps us adapt to stimuli. Nerves can actually adapt to stimuli on the neuronal level. Usually these changes are beneficial to us, but sometimes, unfortunately, they can be maladaptive. And that's what we think happens in patients with irritable bowel syndrome. A primary abnormality that develops is something we call visceral hypersensitivity, which basically just means the nerves are hypersensitive to the signals that come to it from the body. An analogy for this is a burn. If you tap your hand, you feel the touch, but it doesn't hurt. Now imagine you have a big burn there, and you do exactly that same tap. It's going to really, really hurt, right? Even though you may be tapping it with exactly the same pressure for the same amount of time. The nerves, because of the burn, have become very hyperreactive and hypersensitive. That is what we think happens to the nerves in the gut. Because of this, they may interpret normal physiologic signals as being pathologic and causing pain. In addition to a decrease in pain threshold, it may result in changes in the motility of the gut, the compliance of the gut wall, or how much it can stretch to hold contents, and in fluid absorption and secretion. If you think of the intestine as being within an ecosystem of your body, those nerves that innervate the intestine are constantly receiving signals, not only from the body in the form of hormones and nerve signals from the brain, but even from within the gut wall from chemicals that are released by immune cells, and then from inside the gut by the bacteria that live inside our gut and by the food we eat. If you think about that, it's not surprising that because if you come to a doctor with symptoms of irritable bowel syndrome, it may be a process of trial and error to best figure out what management strategies work best for you. It also means that often an integrative approach that combines different types of interventions can be the most successful. So, what interventions do we use to try to make your life feel better? Well, the first set is that lifestyle and diet. And certainly if you can reduce stress in your life, that can be very helpful. Much easier said than done, I know. Sleeping well has been shown to cause a reduction in irritable bowel syndromes. And then exercise. And yes, exercise is even important for your gut. It increases the release of endogenous endorphins in your body. These are the opiate-like chemicals your body normally produces to manage pain. And it can stimulate bowel motility. Multiple studies have shown improvement in symptom scores in patients with irritable bowel syndrome who incorporate a regular exercise routine in their life. By the time patients come to a doctor, almost 100% will have already spent time trying to think what food it was that triggered their symptoms. And indeed, for many patients, avoiding certain foods, particularly those that can affect gut motility, may be helpful. This might mean avoiding caffeine, being careful with fatty foods. Fiber can sometimes trigger symptoms. In patients who have primarily gas, artificial sweeteners can be a problem, and lactose, and certainly carbonated beverages. I mentioned that fiber can be a problem for some patients. Fiber has been something that physicians have used to treat irritable bowel patients for decades. And it actually is very useful in patients with constipation or patients who flip back and forth between diarrhea and constipation. It's not that useful for patients with diarrhea. Many studies have been done over the decades looking at the efficacy of fiber. The one type of fiber that has been most consistently shown to be beneficial is psyllium, which is what is the fiber content of Metamucil. For patients where all this isn't enough, we have a diet that we institute called the low FODMAP diet. FODMAP is basically just an acronym for different groups of short-chain carbohydrates that are not easily digested in the small intestine and as such may be rapidly fermented in the colon, causing gas and sometimes diarrhea. Common FODMAPs that can be problematic include lactose, gluten, fructose, and think about all the foods that have high fructose corn syrup, onions, and garlic. There are also various fruits and vegetables on the list. When we give people the diet, it's usually in the form of, don't eat this, eat this. You'll get a list of foods that are high in FODMAPs that you should try to avoid, and a list of food that are low in FODMAPs that you can eat instead. Many studies have shown improvement in pain, gas symptoms, and diarrhea after about 2 weeks on this diet. Now, the diet is a pretty broad elimination diet. We definitely do not want you on it forever. Generally, what we recommend is that people adhere to the diet strictly for 6 to 8 weeks, and then start very slowly and methodically adding back foods one by one so that in each patient we can figure out what foods are really problematic to that particular patient. Most patients will be able to tolerate some FODMAPs, not others. For many patients who have mild irritable bowel syndrome, these types of interventions are all you need. However, for patients with more moderate or severe IBS, we often need to use other modalities such as medications. Traditionally, the medications we have used over the decades have been those targeted at gut motility. There are drugs that help relax bowel spasm and can reduce cramping. These are drugs such as Bentyl or Levsin, and actually peppermint oil can be very useful, particularly if administered in a slow-release, long-acting type of preparation. The one that is commonly available in drugstores is IBGard. A warning about peppermint oil is that peppermint can worsen gastroesophageal reflux. So if you get symptoms as well of heartburn, regurgitation, or other reflux symptoms, you probably want to stay away from that particular treatment. For patients with diarrhea, we'll use antidiarrheals, like the Imodium you use if you get sick when you're traveling, or a prescription drug called Lamodal. And instead of administering it usually like they instruct on the box, patients with chronic frequent diarrhea will take the Imodium at regular intervals during the day to suppress that. For constipation, not surprisingly, the first-line treatment is laxatives. Laxatives can help with bowel movements either by directly stimulating the gut or secondarily by drawing fluid into the intestine and secondarily stimulating bowel contractions and softening the stool. All laxatives work by one of these two mechanisms, whether they're over-the-counter or prescription drugs we prescribe. At Hopkins, by far and away, the drug we usually recommend first is Miralax. We like Miralax because it is very gentle, it is safe, it is not absorbed by the body, and it is easy to titrate and adjust the doses you need to try to keep your bowels regular. A newer approach, instead of targeting motility, is trying to target the microbiome. We know the microbiome is very important, and in irritable bowel syndrome, there actually have been studies that takes stool bacteria from patients with IBS with constipation and place them in the intestines of specially prepared rats, and those rats develop the visceral hypersensitivity I talked about earlier. There is another disorder in the GI world related to the microbiome that many of you may also be familiar with, which is called small intestinal bacterial overgrowth, or SIBO. And it's been getting a lot of publicity over recent years. There's a huge overlap between SIBO and irritable bowel syndrome, and both in terms that they can both cause very similar symptom presentations. Certainly some patients diagnosed with IBS may have SIBO, and in treating the SIBO may get lasting improvement in their symptoms. And then there are probably many patients who have both the neurologic abnormalities in IBS and bacterial overgrowth. We have two ways of trying to intervene with the microbiome. The first is probiotics, which have become very popular lately. Unfortunately, studies that look at the benefit of probiotics in IBS are very variable still. It's hard to compare studies because almost everyone uses a different preparation of probiotics. In general, there is a trend towards a significant reduction in gassiness and abdominal pain, but the information is still not clear-cut. A few words of warning about probiotics is that we don't know all the long-term effects of various of these bacteria and the products they produce. And so a little bit of caution should be taken when you consider taking probiotics. In general, your drugstore brands contain strains of bacteria and have been that we consider safe. They've been around just the track record for many years and seem to be safe. I would definitely be careful about taking probiotics sold on the internet. And while biodiversity in your gut flora is a good thing, when you have probiotics that brag that they have 30 different strains of bacteria, we don't know, and they are being disingenuous if they say they do all the things these bacteria can do. So a little bit of caution. The other thing is that you should not be on probiotics forever. And in general, I recommend that you only use them for about 1 to 2 months at the most. The other way we have of trying to intervene with the microbiome is to use antibiotics. And in the IBS world, we usually use a drug called rifaximin or Xifaxan. This has been FDA approved for irritable bowel with diarrhea. The appealing thing about rifaximin is that it is really not absorbed from the intestine, so you don't generally get the systemic effects of antibiotics that you might get otherwise. There are several large studies, 3 now, that show benefit in giving patients with IBS and diarrhea a course of Xifaxan, and these patients were not screened at all for bacterial overgrowth. And in these studies, about 40% of patients improved after the Xifaxan, with an improvement lasting up to about 10 weeks. Studies have not looked beyond 10 weeks, so it may be longer, we just don't know. So far, the treatments or medications that I've talked about have generally targeted stimuli that the nervous system may be reacting to. And so why don't we try to direct treatments towards the underlying abnormality in the nervous system? And in fact, we're doing that more and more now. The drugs we use are antidepressants. The reason they work is that the antidepressants are designed to modulate levels of chemicals that nerves use to communicate with each other in the brain, particularly serotonin and norepinephrine. The nerves in the gut nervous system use exactly those same chemicals. And often we can modulate the gut levels at much lower doses than psychiatrists will use for anxiety or depression. Different antidepressants target norepinephrine and serotonin to different degrees, and in turn will have different effects on the GI system. And we try to target what antidepressant drug we might give you based on what will work best for a particular patient's symptoms. There are studies looking at the efficacy of this, and in general, they show that there can be a 20 to 40% improvement in patients with pretty severe, significant irritable bowel disease. Anecdotally, my guess is these studies are old, and I think we've gotten much better drugs now and gotten much better at using those drugs. So I suspect that if these studies were to be repeated now, the number may actually be higher. Unfortunately, about 18% of patients seem to get side effects from these drugs. Because of this, there have been efforts to try to develop drugs that target serotonin receptors or opioid receptors that are very specific only to the gut. And there are some on the market. One is Viberzi, which is advertised, it seems to me, every night on TV. That is targeted for patients with diarrhea. There is another drug called Elocitron or Lotronics that is also works on a gut serotonin receptor to diminish diarrhea. And a fairly new drug for constipation called Motegrity or Prucalopride that works on a different gut serotonin receptor and helps with constipation. Unfortunately, particularly the ones that have been developed for diarrhea can cause serious side effects in some groups of patients, so the use has to be tailored very carefully and is somewhat limited. Another way, though, that we can try to modulate how the mind and the gut talk to each other is through mind-body treatments. So these are treatments that try to use the power of the mind to modulate gut function. And this will include various short-term types of therapy, such as cognitive behavioral therapy, interpersonal therapy, and something called gut-directed hypnotherapy that uses, that puts the patient into a state of relaxation and then tries to places suggestions for better bodily function that go into the subconscious. Also, mindfulness-based stress reduction therapy, which uses meditation, has also been shown to be very helpful. These therapies and programs not only help as far as if you have depression or anxiety, but they have actually been shown to help change how your body reacts to whatever stimuli in your life might be driving your symptoms, and have been shown to modify the visceral hypersensitivity in physiologic-based studies. Finally, acupuncture can be very helpful. Acupuncture increases endorphin release. It can affect bowel motility. It can mediate serotonin activity within the bowel. And many studies have shown benefit by using acupuncture. So if you have mild irritable bowel syndrome, just some modification in diet and lifestyle may be adequate. But for many patients, they will need medication, or if these mind-body therapies are available and the patient is willing to do them, they can help by themselves or together with medication. In general, the best results seem to happen from an integrative approach that incorporates a couple of modalities. So in summary, irritable bowel syndrome is a very common disorder. It is a functional disorder. There is no inflammation in your gut. It does not increase your risk of cancer or shorten your life, but it can significantly affect quality of life. It is basically consists of abdominal pain with altered bowel movements. It is really a disorder of the brain-gut axis, and good results in treatment are best achieved through tailoring your treatment to the needs of a specific patient and their symptoms, and by using a multimodality approach. Thank you.